Thank you for joining the Social Risk Coding and Documentation Training module. I'm joined today by Rishi Manchanda and Sarah DeSilvi, who will be your presenters for this module. Rishi, I'll now pass it off to you to get us started.
Thank you so much, Talene, and I'm so happy to be joined today by my friend and colleague, Sarah DeSilvi. Hi, Sarah.
Hi, Rishi.
It's going to be a treat for us, at least, to talk to each other today, and I hope you guys enjoyed this as well. Today, we hope to cover a couple of key learning objectives. One, by the end of the session, we hope you'll be able to describe opportunities to identify social risk and advance equity using these new evaluation and management coding guidelines, the E&M coding guidelines. We hope you'll be able to list specific ways to code social risk using these guidelines, and then identify ways in which that coding of social risk can help improve both the care of patients and help you advance equity, and depending on the kind of payment model that you're working in, also increase your access to revenue for your practice. Here are some key questions that we'll address to be able to meet those objectives. What are these guidelines? How can my practice code for them, code for social risk using them? And then what simple steps can we take to improve care, as I mentioned. And so with that, I'll spend a moment here just describing the new coding guidelines. And Sarah, I'm wondering if, as we think about the new coding guidelines, I'll take maybe a couple slides here just to describe this, and I'll hand it over to you in the next just to talk about social risk. That's cool.
That sounds great.
Right. So why does coding matter? I think all of you in your settings as part of the School-Based Health Alliance know that medical coding is about gathering information, taking information around the whole host of data related to patient care, and then translating them into alphanumeric codes. And that set of codes is really helpful to both give us a really more complete picture of the complexity of a patient's health, and then also, of course, to help us bill and help us achieve better financial success. Now, under value-based payment programs, coding can also be really helpful, not necessarily to bill for a specific encounter, but to be able to lead to higher reimbursement overall, depending on what's incentivized, especially if social risk data collection and action is incentivized. There's a lot more that we'll talk about in a second, and I think I know Sarah's going to speak about coding as one mechanism of being able to capture information, the way our coders kind of do the work for us, and being able to, as clinicians, right, to be able to capture information. But there's other ways of being able to capture the value of information when you're meeting with a patient and talking about their social risk that we'll speak about. But with that, I'll mention that there's a lot of work, of course, that many of you are doing and that many people across the country are doing right now in healthcare settings, including federally qualified health centers, to be able to screen for social needs. This is welcome news. This is excellent news. But we also recognize that while that's happening, especially using these Z codes, as you see here, to capture information on the screen for social needs, to screen for non-medical factors that influence health, we recognize that not a lot of settings are actually capturing that data. We're screening for it, but we're not necessarily capturing that or using that information as well as we could. So that's the challenge that we presented with today. And in that context, the question is, what are these new coding guidelines and why do they matter? And so for that, Sarah, I'll turn it to you.
Thank you, Rishi. So my principal job on a daily basis is I'm a rural family practice provider. So it's been a long time, I can testify, since there's been an update. So in 2021, the American Medical Association and the Center for Medicare Medicaid Services deployed the landmark E&M, means Evaluation and Management Office Visit Code Changes. So January 1st, 2021. It's the first overhaul of E&M office visit documentation in 30 years. So the goal of these coding guidelines were to decrease documentation burnout and note bloat, to make code level selection more intuitive, to decrease the need for audits through the addition and expansion of key definitions, but to retain the current code distribution. So the same codes stuck around, they just have clearer meanings and clear pathways to arrive at them. Always, from accountability perspective, code levels should be based on clinicians' work in managing the patient's problems, with focus on decision-making and not simply on a volume of tests and treatments, like ensuring that we're doing the right thing for our patients as opposed to upcoding. That's the core principle of ethical practice. Next slide, please. So you basically now, we recognize that coding happens in two different ways. And when we're using coding in this term, we're talking about accounting for care, like the heft of the visit. So clinicians code directly in some settings, sometimes coders in the background audit a visit after the fact, but there's really two main choices in order to decide on what level of evaluation and management is appropriate. So one is driven by medical decision-making, or MDM. You'll see that for the rest of the presentation, which is really the complexity, everything from the complexity of the history I took, the complexity of the data I reviewed, the complexity of decision-making. And the other one's just based simply on time, on the total time of the encounter. The important thing to note is that within a day, it allows you to review lab results either before the visit or after the visit, collaborate with other consults. All of that time during that day can be applied to the total time of the visit. So when they say total time, it's just not just the space that the patient's in front of you in that moment. So if you are going to do the medical decision-making element, this is where the social risk bit comes in mind. So we're going to unpack how that works, and then we'll talk about social risk as a factor in the next slide. So understanding how to appropriately document a visit to code and bill based on the medical decision-making can result in a higher level of compensation. So there are four main levels. Those, again, did not change. So it's still the same as it ever was. So you have straightforward, low, moderate, high, and they each correlate with these different E&M visit levels. And then there's three different factors, as I mentioned. So determining level of complexity, you have to consider the problems, like the number of problems you address, including whether they're chronic or acute. And this is all in the history taking. The data, right? The amount or complexity of the data you reviewed and analyzed for the course of that visit. And then this is where the social risk bit comes in mind. Social risk is management risk. So in that last bit, the risk of complications or morbidity or mortality align with patient management. So capturing social needs and social risk data is important here. Did social risk affect the complexity of the plan or the diagnosis or treatment for that patient? And so this is what the E&M coding guidelines have allowed. Next slide. So the guidelines can create opportunities to advance health equity, like seriously, by improving the capture and consideration of patient social risk data, especially related to medical decision-making. This paves the way for incentives to better support health and social care integration, because this is literally a very clear incentive, and practice level equity work related to social needs. It's really important to talk about how this happens. So the E&M coding guidelines allow providers to use social risk to achieve these moderate risk levels through MDM, but there's really two pathways here. So it can just simply be in the story. You can document all of the different factors regarding social risk you considered when you were making that plan, write the story in your note, and when an audit came by, someone would clearly say, these were absolutely, like this was absolutely reflected, the social risk is in here, that's an appropriate code. You can also use literal codes to document your work. So those codes that Rishi was talking about earlier, those Z codes, if you drop them into your visit and integrate that into your assessment and plan, that also is suitable for accounting, and it's a tracker. So we can see that that code was represented in that visit, and it will apply to some of the other uses we're talking later on in the talk. We always want to make sure that we remember equity in every encounter when we're trying to address social risks, otherwise we defeat the purpose. So clinicians and coders implement these guidelines without an explicit focus on health equity. They might either miss opportunities to reduce health inequities, including racial health inequities, or even worse, may inadvertently exacerbate them. I had the honor of writing a blog on this when these E&M code lines first came out with my colleague, Dr. Laura Gottlieb from UCSF Siren, really trying to unpack all the complexities across like implementation, policy, quality measurement, and risk. But it's important just to keep this in mind. You don't want to add adverse burden to the patient. You don't want to add adverse burden to the system. And you certainly don't want to misalign yourself with measures that don't achieve the goal of health equity.
Sarah, thanks so much, especially for mentioning that article. That was for me personally such an eye-opening way to both orient me to the new coding guidelines, as well as to unpack the real importance of these coding guidelines for both understanding and integrating social care into healthcare practice, as well as being able to leverage these coding guidelines and think about equity in meaningful ways. So we'll make sure that we share that link with folks who are looking at watching this presentation within the SBHA. With that in mind, as we kind of just set the stage a little bit for what the coding guidelines are, why they matter for social needs and equity, let's go a little bit into what this looks like. You know, how can you actually code for this work? And so with that, I think there's a little bit, Sarah, that we can talk about, you know, about why this matters. This is just a set of bullet points that came out of conversations that we've had, and I know conversations that we've had with many others across the country. But what would you say, you know, without reading off the list necessarily, what resonates from this list, or maybe what's not on this list that resonates about why it's so important to collect this information in the first place, Sarah?
Well, you and I have talked about this, I think, at great length, but the primary driver for me is just being able to tell the story of my patients, right? Mm-hmm. So if there is a real sincere, like, what is the first thing I think of is I want to tell the patient's story. And the patient knows that social risk is contributing to the complexity of their experience. So being able to represent that in the visit is aligned with their goals. And we've also talked, of course, about just, we've talked about that in other areas too, about how missing risk within value-based healthcare is a big risk, right? So we know how within value-based healthcare, we use hierarchical condition coding, we use all kinds of risk stratification methods. And if social risk isn't in there somehow, then we're really missing the boat on affecting the drivers that are affecting the outcomes for our patients.
Yeah, I really want to double click on that first point you made, which is, you know, the ability just to get to know your patient better. And one of the things that we found a lot, and it's been just repeatedly eye-opening every time we hear this, is the way in which clinicians who think they know their patients, right? Then in the course of a practice, you know, a busy day, seeing 25 patients in the day, all of a sudden, like, the medical system that they work with will have screened for, you know, the social needs for a patient that they've known for a long time, and find that the patient now today decided to disclose an issue like food insecurity. And the clinician, you know, walks in the room and says, well, it looks like there's food insecurity. This must be wrong, because, you know, we know each other. It doesn't come up before. And the patient says, no, actually, I just haven't felt like I've been able to share this with you, but today I wanted to share that I've been struggling a little bit to make ends meet. That's a story that actually I heard from a clinician years ago when we were starting to help some practices around the country to integrate social needs. And the thing that was most compelling about that was the clinician's own recognition of the fact that what he knew of this relationship all of a sudden went to a whole level deeper. This kind of therapeutic bond, this almost sacred relationship, right, that exists between a clinician and a patient. This trust means something differently when you're able to understand now the full context of that person's life, and when the trust that you have allows for that person to now disclose information that's so critically important to who they are and the struggles they're going through. For me, I feel like the ability to cut social risk is about, as you were saying as well, the ability to capture the story of a patient, but then to get to know your patient and to strengthen that relationship that gives us, frankly, the joy that we need to keep them going. So I just wanted to say amen to your first point there. And then, of course, there's many other points, as you mentioned, Sarah, as well, right, around the value of collecting social risk, both for value-based payment, to be able to understand inequities, right, in the first place. We're talking more, as we should, about racial inequities and inequities based on sexual orientation and gender identity, for example. Social risk information allows us to understand the patterns of inequity better, right? Both by race and by place and by factors like housing and food, and get a better ability, a better insight into what's driving inequities in the first place.
I just want to add two more things. I feel we can go on forever. So I just want to honor the two things I hear next when we say what we just said. So one is, what do patients really want you to know, right? And there's a lot of qualitative literature out there. I think of the work of Deepak Palak-Shapa that literally state that, yes, patients want you to know the things that are affecting them. So don't worry about asking, right? And the next thing is, what do I do if I can't do anything, right? The other thing is just holding space. You know, nursing has this care not cure model. Like, it's okay to know complex things and not have solutions for them, right? Because that's like the daily experience of our patients, right? Experiencing complex things and not having solutions for them. So just wanted to anticipate that those are the first two things I always hear, but what if, and then what if I can't? So there's literature out there to support those concerns.
Right, Sarah, and that last point is such an important one, because again, I think that it's not gonna be I think there's gonna be a lot of nodding heads as people hear that point in this presentation, because we hear it so often, right? What if we ask for these things but we don't have something to tell them? What do we do? That gap in efficacy comes up a lot. And one of the things that to your point, what I love about the care not cure, we do it all the time. And one of the things that we see is understanding this by putting it in a different context. Like, what about depression? What if your patient was depressed, right? If you don't necessarily have exactly, if you're not a psychiatrist, you're still able and still compelled, right, to ask if somebody is feeling depressed. And in fact, we screen for these things routinely because we know how it matters to the health of our patients. So you don't have to be a specialist or have every single specific solution in your toolkit right there and then in that encounter to be able to just ask the question and establish that space for the patient to care, not cure. So I love that. As you said, we could go on about this.
I know we could probably.
As everybody can hear, like, we think that there's a lot of reasons to collect social risk information, and maybe let's get to the how. And Sarah, I'll turn it to you maybe to talk a little bit more about, in the context of these coding guidelines, what this looks like.
Yeah, that sounds great. So this is a fairly complex slide, but you can really see it's representing the problem data risk level criteria in the columns there, right? So there's a pop out talking about how to achieve moderate complexity. And for the sake of novices, moderate complexity is a ending of a 4, a level 4 code. So in this instance, documenting or discussing how social risk implemented or affected the assessment and plan of a visit allows you to upcode from a 1.3 to a 1.4. And I really want to give an anecdote here because I think it's really important because this happens every single day, right? So when financial drivers are limiting a diabetes medication and you spend time finding a coupon or picking a different medication or trying to find something that meets their needs, or when food insecurity is driving someone's uncontrolled A1C level and you need to refer them to a program like at the local food bank that has specific diabetic care packages, like the literature of our colleague Hilary Seligman. There's a lot out there, right? So we know all the different things we're considering, how homelessness affects discharge from the hospital, like all of these different elements or considerations we have in our minds and the lives of our patients every single day. So putting them either with a code, like we'll see in a couple of minutes, or in just the story, allows you to represent the risk that the patient's experiencing and the risk in the management and achieve that different coding level.
So just because of the audience here, especially within the School-Based Health Alliance or a lot of school-based health centers, another example that comes to mind is the, if you're spending time thinking about the ways in which the conditions of housing impact your pediatric patient's asthma, right? That's information that's happening in many cases day in, day out. This is a way to start to capture.
Or couch surfing teenager. I mean, this is like my daily beat in adolescent medicine, right?
Yeah,
Yeah.
exactly. And so I know that there's so many different ways in which so many different social risks and social needs that we're routinely capturing. It's not like, clinicians aren't talking to patients every day about social factors, social needs, and social risks in the context of care. This is a better way to capture that. And I'll turn it back to you to maybe just voice over the Z codes.
Yeah, so we did see a slide reference. It was the Office of Minority Health slide on utilization of Z codes that was in a table a little bit earlier. This is just a kind of a pop out of some of the many different Z codes within ICD-10-CM that exist at this time. If you want to diagnose and add that specific term to your note, I do want to state that there's a pretty exciting update to these that's coming very, very shortly in October due to the work of the Gravity Project. So you'll have specific codes for food insecurity, housing instability, and either sheltered or unsheltered homelessness. So the simplest way, if you don't want to write it all out, if you're not a free texter, is literally to represent that this concern was considered in the management of that condition, and then that achieves that social risk representation for complexity.
Yeah, so underline that. This concern was considered in management of this condition, right?
Exactly.
Is such a key kind of takeaway, I think. And last but not least, as we think about understand a bit more about social needs, social risks, and how to capture that information and how it impacts it within the coding guidelines. And again, this is just using the codes, Sarah, right? That you pointed out, right? There's also ways to capture that in the text, right, of your note, and allow for a coder or an auditor later on to be able to verify, oh yeah, this is this person, this clinician clearly did consider the social complexity. So you can use your notes, and the codes can be used specifically as well. The big question, of course, as we talked about at the top of this, is why does this matter not just for the care of your patient, but to the broader commitment to equity, and also to the sustainability of your work and this work of health and social care integration. I'll take a couple of slides here just to describe some steps to be able to advance equity and sustainability, and then I'll turn it to Sarah before we wrap up today. One of the first steps to being able to advance equity and sustainability for your work, especially when it comes to integrating health and social care, is just involving the patients you serve and the community you serve in these dialogues. We take too much on our plate sometimes, or too much on our shoulders to be able to think about these complex questions without involving the very people whose lives are impacted most by them. And so how is your practice involving patients and other members who belong to historically marginalized communities in your efforts to advance health equity, including your efforts to integrate health and social care? Or, meaning, are you talking to patients? Are you talking to community advisory boards or councils? Are you talking to your board if you're an FQHC, right, about the work to be able to integrate social risk information into your coding and, more importantly, your overall care? What are the patterns of inequity that they perceive, right, when it comes to healthcare access and quality and outcomes? And as importantly, what are the social and the structural drivers that they identify as the root causes for those inequities? There's so much expertise that exists in the lives of our patients, right? Our patients are experts in their own lives. And the members of the communities that we serve are experts in these social and structural conditions, more so than we can ever sometimes hope to be. Not asking those experts, not asking those people with lived experience can be a mistake when pursuing. So involving your patients and community members is a key step, and it's important, of course, to consider how to authentically and equitably compensate them for those insights and contributions. Another important step is to just identify the inequity itself that you're trying to address and the patterns of inequity that exist. So how are you collecting first, information and documentation of important drivers of or important demographics, right, that allow us to identify inequity? So, for example, how well are you collecting information on race, ethnicity, and language? How well are you collecting information on sexual orientation and gender identity? And how well are you collecting information on patient income and geographic information, like their address? There's opportunities for continuous improvement here, as we know, especially when it comes to race, ethnicity, and language information. Beyond collecting that, though, there's also a question about what's your capacity to analyze that information? How well does your practice analyze this information? And as importantly, do you have partners that you can work with sometimes to improve that capacity? Here's an example that you'll be able to read in the bottom here of a clinic, let's call it Clinic X, that takes some of their data to be able to identify whether there's patterns of inequity when it comes to asthma diagnosis and associated utilization of the emergency department among children. And they decided to look at this data, not just by race and by utilization patterns, but also by place, looking in specific zip codes. And we're working with a partner because they recognize they don't have that kind of data analysis capability in-house. They identified that there are inequities in health status and ED utilization. Those inequities are among Black and Latinx children compared to white counterparts who live in the same zip code. And so this is an important step. You can't address equity until you find out where the inequity is. The next step then, of course, I'll turn to Sarah, is what is it? How do you use social risk? Be able to do something.
I can't not comment on what you were just talking about, Rishi. So from a data justice perspective, we call that the injustice of invisibility, right? Mm-hmm. So if you're not naming or defining the concern, if it's hidden from you, it's the injustice of being invisible, right? So the next thing is, Rishi and I could obviously talk about this a lot. So is using social risk data to better understand and address patterns of inequities. So to what extent are social risk data associated with patterns of inequity identified? How are you working with community partners to address the social and structural drivers? And I actually think about this as a really important step of moving from like a community health needs assessment or publicly freely available data to analyzing patterns of data in population health. So in order to actually affect any change, we know very clearly you have to move from the individual to the structural drivers, right? So there's a huge movement in healthcare right now to use publicly freely available data, such as things like multiple moves or credit histories or anything that's available kind of the interwebs to predict risk. But the real risk is represented by the experience of the person multiplied according to the population. So my takeaway here is it really is the best version of population health when you're able to capture information at the point of the patient, extrapolate it over the whole population, and then really start to affect change. Next slide, please. Oh, do you have any comments there?
No, I think just that the ability to do that is exponentially increased when you do it with partners.
Correct. Oh, yeah, I know you're saying.
yeah, exactly. That's the amen to that point. And I think as people kind of read through and take the time to kind of read through the examples, they'll see kind of what that might look like. But yeah, Sarah, go ahead.
Well, I actually think I think this is an important thing to state. Like, I know that you took us back there, but I want to kind of settle there one more time. So, yeah, I do work within this project called the Gravity Project, and one of the things that we say there, we identify problems in clinical settings, but we solve them in communities, right? It is really critical to lean on community partners, both for their expertise. They've been working in this field for a very, very long time, and because this is the only way to affect change. So whether it's medical legal partnerships such as the CBO and the legal aid organization, or working with your community action agency, I mean, there really is no way to address the actual cause until you reach out of your clinical setting and collaborate with individuals outside of the clinical ecosystem, even if your clinical ecosystem is the school. The last thing, or I think this is one of the last things, is talking about social risk data to do a better job under value-based care. We talked about this a little bit earlier, and this is actually very true to form. Again, I didn't say where I work, but I work in Vermont, right? So, which is very invested in the value-based payment reform initiative. And at present, really, one of the major hindrances and difficulties in representing social risk in claims, because those ICD-10 CM codes we were talking about are part of the driver of how accountable care organizations or CMS or a state Medicaid assesses the risk of their patients. So if that code is not there, this is where those codes really, really matter. If that Z code's not in claims, it's hidden from view, right? That risk of invisibility comes right on back, right? So if your Z code is able to be in the claim stream, go to Medicaid, go to Medicare, go to the accountable care organization, then it's able to become part of the modeling for the prospective risk of that patient. So instead of just having the uncontrolled type 1 diabetes of your teenage patient, you have uncontrolled type 1 diabetes in the presence of food insecurity and the presence of homelessness, right? And you're like, oh, I know what to do now, right? Yeah. So I don't know if you want to speak to the example, Rishi, or?
No, I think, well, I think you spoke to it beautifully. I think that especially if you're a clinician listening to this, or you're an administrator listening to this, and you're not necessarily sure about how this might link up, what we put here as a question is just go to colleagues within the organization. Sometimes if you're affiliated with a larger health system or with a network of QHCs or otherwise, take this as an opportunity to ask, how much exposure do we have to value-based payment models or alternative payment models? And to what extent are there incentives already baked in there that allow us to support the collection and the action on social risk information? Just taking this information can be a really powerful first step as you think about how to use social risk data to do better under value-based payment. Last but not least, we've covered so much ground, Sarah, today, as is typical for our conversations. But today, remarkably, we in 20 odd minutes, we were able to cover a lot of ground. I think we hope that out of this conversation, Sarah and I, that we just had, that you're now better able to describe opportunities to identify social risk, advance equity using these new coding guidelines, why they matter. List a couple of ways, specific ways to code for social risk. You heard Sarah talk about the use of medical decision-making specifically to be able to use social risk data to identify moderate risk using those new coding guidelines. And then also, hopefully you'll now be able to describe a few of the ways in which social risk coding and the data that we're talking about here can be so vital to your efforts to be able to improve care for your patients, to improve equity for the populations and communities you serve, and hopefully to be able to increase more revenue to support your ongoing sustainability. I would say last but not least, as you can tell with the passion that Sarah and I share for this, one of the other things hopefully you'll be able to recap is social risk data is a means by which to maintain and sustain your joy in your practice because of the opportunities it provides to better know and care for your patients. Sarah, I can't thank you enough for your time today. For everybody who is listening to this right now for this training module on social needs coding and documentation, thank you. Sarah, I'll give you the last word.
Oh, I'm just very, very honored to be part of this. And as far as there's always going to be one more thing. I was like, oh, I forgot to mention patient-centered medical home and how this figures in with coding. With an we could go, maybe we'll do a part 2. But thank you so much for your time, Rishi and Talina, and Health Begins. It's always a joy to talk about this very unique passion of mine, social risk coding.
Thanks for that incredible conversation, Sarah, as always. And thanks to all of you. Be well.
Thank you all.